Hello, hello, and welcome to the lecture on renal calculi. I'm Mrs. White, and we are going to use our next-gen template as we do for these lectures, including recognizing and analyzing cues, so those signs and symptoms, things in the patient history, what's relevant, what's irrelevant. We'll go down to relevant diagnostics. How do we diagnose this? Are there any nursing considerations for these diagnostic tests? Prioritizing hypothesis. These are our priorities. These are the things that will harm the patient the most and the fastest. What happens if we do treatment? What happens if we don't? So we need to prioritize there. We're going to generate solutions and take action. So that is our implementation phase and evaluation. So these are nursing measures, some treatment for the condition, monitoring, education, ethical concerns, and then, of course, medications to know. All right, so renal calculi are a little bit involved. There's a lot to them to sort of know about them since there's so many different types, but we'll pick it apart the best we can. Okay, so let's start with what are renal calculi? So that's kidney stones. They can also be bladder stones. The difference is whether we would call it maybe nephrolithiasis, urolithiasis is basically based on the location. Renal calculi develop when crystal-forming substances are not reduced by the kidney, so increased concentration of solutes in the urine. Okay, so let's jump right into it. So what are some of the risk factors for renal calculi? Increasing age. The older you are, the more increased the risk. Immobility, obesity, dehydration. So kidney stones tend to occur more in the summer or hot months. Previous history, family history of stones, abnormalities in the urethra and any of the I'm losing the word. So any of the structures, so something like a stricture would make it more likely that if you had a stone, it could cause a problem. So some other risk factors, having gout, right? Because that increases the uric acid, so that could lead to uric acid stones. Hypercalcemia, just having too much calcium. And that hypercalcemia could be related to something like a cancer. It could be related to hyperparathyroidism. So how do we know that the patient has a kidney stone? Somebody once said that having a kidney stone, the pain is like having a baby, but it's worse than having a baby. So I've heard. I've never had a kidney stone. But they say the reason they know this is because if you have a baby and the pain, you often would want another baby, but nobody ever says they want another kidney stone. So that may be something. All right, so the biggest signs and symptom that you're going to see is severe pain, sudden severe pain. And that pain is often in the back, the flank, lower abdomen. The pain can actually clue us in on where the stone is. Flank pain, it's in the kidney or the upper ureter, and as it moves down, the pain tends to travel. Often, the pain radiates into the abdomen and the scrotum as it moves from down into the ureter and bladder. There's something called renal colic, and that is like this acute lumbar pain. Very, very painful. You can always tell folks who have the renal calculi, they have the kidney stone dance. They can't sit still. The pain is excruciating for them. The pain is so severe, so sharp, and so intense that it's often accompanied by nausea and vomiting, pallor, and diaphoresis or sweating. All right, so let's move on to how do we diagnose a kidney stone. A non-contrast CT will help us visualize the stone as well as an ultrasound. Somebody comes into the emergency department, we often send them right for the CT scan. Ultrasounds take a little longer, a little more uncomfortable. We can see pretty quick with a CT. Urinalysis can give us some clues, including our urine pH. Serum electrolytes can also clue us in on the type of stone that the person may have. And we want to definitely look at the person's renal function. Anytime we have a stone, it can obstruct. When we have obstruction, we have urine backup. That urine backup can destroy the kidney. So just taking a step back to the urinalysis for a moment, if the person has a UA and they have a kidney stone, often what we'll see is hematuria, white blood cells, crystals, and bacteria in the urinalysis. So I want to take a step back now and just look at the different types of stones, because they're important to know that there are 5 different types of stones. There's calcium oxalate stones, calcium phosphate stones, struvite stones, uric acid stones, and cysteine stones. So calcium oxalate is going to be your most common stone. It's made of calcium oxalate and phosphate. Calcium phosphate stones are made with calcium oxalate and phosphate as well. I'm sorry, they have the phosphate where the oxalate really is in the calcium oxalate. Struvite stones tend to get very large. They're made of magnesium, ammonia, and phosphate. And for those, because they get so large, they often need surgery to remove them. Uric acid stones are due to increased uric acid. And then also cysteine is a specific stone that's related to the cysteine levels. Not the most common. Most common you're going to see is calcium oxalate, followed by some calcium phosphate, those struvite stones. So we're going to talk about those a little bit more. But basically what happens to cause the patient so much trouble is a stone by itself can be a non-obstructing stone, and we can pass it with some pain, sometimes not pain, but the larger the stone, the more likely it's going to become stuck, right? And they often become stuck at the ureteropelvic joint, which then causes the ureter to become dilated. There's damage, which leads to hematuria. Stasis of urine leads to infection, and obstruction leads to hydronephrosis and kidney damage. So I once took care of a patient, it wasn't even that long ago. He came in with a kidney stone and he ended up with sepsis and ventilated. And I mean, he had terrible sepsis, which in turn led to some bacterial translocation and clotting issues where he suffered a GI bleed. So these can be very serious and start out rather mild and progress. And especially the older person, more comorbidities, much harder to treat. So what are our priority hypotheses for something like the renal calculi? What can you think of? Hopefully you're thinking that we're concerned about urinary stasis and the risk of sepsis. We're absolutely concerned with pain control. And our goals for our patient with renal calculi are to protect the kidneys, maintain urine flow, prevent urinary stasis, and promote expulsion of the stone. So there's many different ways we can get to doing that for the patient and help them along the way. Some, it's just painful. We have to just support them with pain meds throughout, and they will pass the stone for our smaller non-obstructing stones. But for some, we have to do other things. So in total, pretty much all of our renal calculi need increased fluids. Now, there's some concern. Sometimes you don't necessarily want to push fluids if somebody has renal colic. We want to make sure that they have enough fluid, but we don't want to overload them because that can lead to increased renal colic. However, that's usually an outlier, right? We want to make sure that we're increasing the fluids. For calcium oxalate stones, we want to basically decrease their oxalate, the protein, the sodium, avoid vitamin C, but increase the dietary calcium. It's very interesting. If anybody thinks to ask me why, I'll tell you in class. And we want to increase fruits and veggies. Moist heat is okay for all of the stones because it can be a comfort measure. Struvite, we said they often will need surgery. Going back to the fluids, I would say that they probably need about 3 liters in 24 hours. That's pretty standard. We want to make sure they have plenty of urine output, at least 2.5 liters a day output. And the preferred fluid is water. We don't want to give them coffee, tea, cola, right? We want to make sure that we're giving them good fluids. They may actually need IV fluids. Again, low sodium diet for the majority of these. Assessing their pain is paramount. They may have nausea and vomiting. It is appropriate if somebody is acutely ill with a stone, they're acutely in pain, that we would go ahead and give them the opioid. So opioids like Dilaudid. Sometimes we do give Toradol and things like that, but we have to balance that with the renal function. So other than that, let's see, some of the other things. Always check for urinary retention when somebody has a stone. How do we get the stones out? The ones that can pass on their own, again, it's supporting the person. We give them medications, which we'll discuss in a minute. But we give them medications to sort of relax everything and let the stone pass as much as it can. Have them strain their urine, right? We need a special urine strainer. There's pictures in the textbook. You can also Google them, but we want to strain all urine because we want to catch the stones. And if we do get a stone, we do want to send it to the lab. So we have a lithotripsy, which uses lasers, ultrasonic, etc., to break up the stones. And then the stone can then be excreted in the urine. The risks of a lithotripsy are hemorrhage, infection, and obstruction. As a result of a lithotripsy, though, a person may need a stent for some time after. A stent will just kind of hold those ureters open, allow the stone to pass. So after a lithotripsy, hematuria can occur, right? So there could be some bleeding in the urine, but there should not be big clots. And again, the good teaching is to encourage the fluids, make sure they have at least 3 liters in, no coffee, cola, or tea, and they often will need antibiotics. There's something called a percutaneous I just stumbled over my words, didn't I? Percutaneous surgery. Basically, it's a lithotripsy, but instead of just going through the, like, on top of the skin, they actually make an incision and go in. So the percutaneous nephrolithotripsy. So that reminds you that they're going to basically have an incision. Sometimes we can use a needle. The problem with when we're doing percutaneous nephrostomies and things like that is that we often need a nephrostomy tube. Nephrostomy tubes are indicated when there is an acute backup of urine into the kidneys. We have to drain them. And we'll often, after having to do surgery on a renal calculi, would put a nephrostomy tube, at least for some time, to make sure that the kidney is able to drain and that we're capturing any of the stones that are broken up and coming out. So it's important to always monitor that that nephrostomy tube is flowing. We do flush nephrostomy tubes, not like bladder irrigation, right? Not like that at all. When we do flush a nephrostomy tube, it is with a doctor's order, and it's usually just about 10 mLs of saline, sterile saline, that we would instill to keep it open. I want to take a minute to talk about some of the things that increase oxalate. So oxalate is increased by fat malabsorption, ingestion of ethylene glycol, and increased levels of vitamin C, which is why we said to avoid vitamin C supplements. Oxalate is also increased by certain foods, including rhubarb, spinach, chocolate, nuts, beer, tea, beets, cabbage, sweet potatoes. Our uric acid stones, some of the risk factors for them are diarrhea, diabetes because of the ketones, so things that make us acidotic. Hyperuricemia, so things like gout, tumor lysis syndrome. Thiazides, salicylates, and of course the purines, which we know all about from our talks on gout. So we want to teach the patient with uric acid stones to avoid alcohol, organ meats, red meats, sardines, things of that nature. Cystine, I said it's very rare. That's a genetic disorder that would cause those. And those struvite, those really large stones, those are very common with bacteria. So people who have UTIs tend to develop those. All right, so one thing I want to mention as we're taking care of the patient with renal calculi is that if they have pain, and we know they have pain, right? If they have increased pain, especially if it's accompanied by some other signs like being pale or diaphoretic, but just even the increased pain, we want to consider that they might have an obstruction, and you have to constantly think about that. Do they have an obstruction? We want to keep that urine flowing. All right, so medications to know. What are some of the meds that we give for renal calculi? Some of it is like thiazide diuretics, potassium citrate. But the ones that I really want you to think about here, pain meds, NSAIDs, opioids, tamsulosin, alpha adrenergic blockers. So tamsulosin, which we give for BPH as well, and some of the other urinary retentions, even in ladies, that can help relax the neck of the bladder, and it helps relax the smooth muscles so that the stones can pass a little easier, and also calcium channel blockers. So I'm not going to go too much into pharmacology on here, but basically we want to make sure we know the meds. And as far as patient teaching, you have to know how to teach them about the different procedures, whether it's like the shockwave lithotripsy, whether we're doing a uteroscopy where they put a scope in and actually break it up, whether we're doing the percutaneous nephrolithotomy, or any of that. And the thing is that if a patient has a calculus, they have a renal stone, they're more than likely going to develop it again. So we have to teach them the signs and symptoms of early development. And at this point, it is important that we teach them to definitely drink enough fluids to keep their urine pale yellow, the danger signs of obstruction, the dietary changes that are needed, and also people with stones, because they're at high risk for sepsis, we want to teach them about what is sepsis and how to monitor at home, and then we'll monitor them while they're in the hospital. Okay, you have to teach the patient to strain their urine, and that's about it. Outside of making sure we don't have some terrible things happen as a result of the renal calculi, most people have uncomplicated stones. They're painful, and they will never forget them. All right, so that's it. Sorry it bounced over just a little bit, but that's how my brain works.